we will now be moving to Miss Stamos, and she will be discussing the barriers and facilitators to medication adherence.
Thank you. Thank you very much for the presentations we just heard. My name is Katy Samos. I am based in Dallas, Texas, and I work at the Diabetes Health and Wellness Institute, which is part of Baylor Scott and White Health Systems. And we are a community-based organization. We share a building with Parks and Recreation Rec Center, and also with one of the 9 Baylor Community Care Clinics in the Dallas-Fort Worth area that see both insured and uninsured patients. We are located in South Dallas, which is the most underserved part of Dallas County, and it accounts for 11% of all of diabetes in Texas and Dallas. So we have lots of good ground and good soil to work with, and I coordinate and lead all the education programs that we have. We are an accredited program for the diabetes self-management education. We're one of 2 fully recognized CDC sites for the implementation of the National Diabetes Prevention Program. We have a health equity program through Baylor funding, Baylor Scott and White funding for bariatric procedures, 100% free of charge for those patients with diabetes that meet the criteria to have this procedure. So we are quite busy, and I would like to tag along what Ms. Jackson mentioned, that mostly my role is as a health equity champion through all our programs. And the objective for our brief discussion this afternoon is to talk about and explore 2 evidence-based methodologies to have these conversations about insulin, and I would like to refer to it as insulin adherence. Which implies in itself that patients make the choice that they can with the education and with the information and with the tools that they have at hand. And the 2 methodologies that I would like to briefly explore together with you is shared decision-making, which is a model that is being implemented in many large-scale health systems, and which it will be part of Medicare implementation, and also part of how those dollars come to accountable care organizations that implement shared decision making. And what it is a collaborative process where patients and providers share decisions and move forward together. And one would think, well, isn't this what they're already doing? Yet what the literature tells us is that there are, on one hand, barriers that providers have, such as time limitation, having to enter all the data and all the information from patients in the electronic medical records, and mostly their own ability and willingness and spirit to have these conversations in a skillful way that will move the patient forward in making decisions that impact their health and by that also their community in positive ways. As Ms. Sabrina Jackson mentioned at the beginning, when someone is diagnosed with diabetes, they don't think about in 10 years giving themselves the Christmas gift of an amputation. That said, it is a complex paradigm, because we also know from research that the informed or empowered patient, that doesn't necessarily translate into the ability to ask questions or disagree with a practitioner. And the basic driver for that is fear that their care in the future will not be as good or will have barriers because of them raising questions and not being quote and unquote an adherent or compliant patient. Now, to be able to use shared decision making as a tool for changing the conversation, there are some skills and abilities, and this is the second methodology that I would like to describe, such as motivational interviewing. And what motivational interviewing, and I also just think that I'm preaching to the choir here, is a guiding patient-centered counseling style that will enhance motivation for change by clarifying and helping the patient resolve ambivalence about their own behavior change. And the goal of motivational interviewing is to identify and resolve this two-mind thinking between current behaviors and their broader values and goals. And when we talk about this, it's motivational interviewing, and yesterday we were doing a class with some participants on today's call that are community health workers working in a partnership which we have with the city of Dallas and implementing the Stanford model in community in recreation centers. And so something that we were discussing is how motivational interviewing is really not just being nice to people, because when implementing this methodology, we have a clear direction, and there is intentional strategic movement to go towards the goal. And it certainly is not a technique that is easily learned or a gimmick that we pull out of our toolbox at any time. It is really a style of being with people. It is an integration of particular clinical skills that foster motivation for change, because that's what we want to be able to do through having these conversations, is find what is the patient's own motivation. Because when there is that staggering statistic of more than 1/3 of patients never filling in their very first prescription of insulin and 28% not adhering to this treatment a year after, we're thinking, well, where's the gap? And that's what we want to identify. Where are the gaps? How can we build that bridge? And that's where, and I encourage each of us to become better and more skilled at having these conversations, and knowing that although it is not, this methodology is not a panacea or something we can use always, it definitely drives behavior change. And so in order to have these conversations, we need to be able to understand the patient's point of view. And when we think about the time constraints, and then of course of the physicians, of the providers, I can see why they would rather be directive and say, this is what you need to do. You have diabetes, you need insulin. If not, you're going to get worse. And so to listen carefully and be present, there has to be that spirit of wanting to do that. And we all want patients and our community members to be empowered, and we want them to be empowered to share decisions about their own care. And those of us who work in the community know that it is small conversations through time and small changes through time that allow us in population health to move forward as a group. And in having these conversations, we are creating a partnership. We are starting off from a very strong foundation of respect, of autonomy, of not sympathy, but empathy. And the question that we ask, and this is how we start using the methodology, we start using what we call in motivational interviewing the oars. And the oars, as the oars in a rowboat, it's not a speedboat, but it does move the conversation forward. So when asking these questions, having them open-ended, we want to hear what they have to say, because it benefits us to keep in mind that 98% of the care takes place outside a clinical setting. 98%. So that patient is going to go home and do exactly what he or she believes is best practice for them. So having those open-ended questions, affirming the patients. And when I say this, I'm thinking of patients and people in general, because one of the very positive aspects of using this methodology is that by practicing it in any setting, we start to realize how it really is a way of being, by doing reflective listening, by summarizing, which allows the patient to know that we are actually present and we understood what they are saying. So using these skills and abilities and getting better at it is what will benefit this shared decision making and increase patient satisfaction, and that by itself will lead to better health outcomes.
Thank you so much. Yes.
Yes.
Thank you very, very much for a very informative segment. So now we are moving to open Q&A. So we will be sharing many of the questions from the registrants. However, if you have a question that has arisen from today's presentation, we ask that you submit it in the question pod.
Hi everyone, this is Sabrina, and I think the question was about best practices maybe for providers to help with non-adherence. I can't remember. It was something along that line. And I can't remember the exact question, but the idea of doing a diabetes distress questionnaire may be helpful for that scenario when you have clients or patients who may be struggling, with this disease burden and the way their lives are going to be changed forever. having them to do the diabetes distress questionnaire is a really good talking point to start a conversation for one. So it's a really useful tool for a provider to use. And it will also help to indicate if you need to do a referral for your patient to be able to see a behavioral health provider to help them navigate some of the challenges that they have in their the emotions and in terms of coming to grips with this diagnosis and the disease process.
Thank you for a very thorough answer. So our first question is, are there studies that look at non-adherence and how it is impacted by patient education?
There is literature, and you, whoever asked the question and everyone else, we can do a search, and the AADE journal, the American Association of Diabetes Educators, has conducted several studies regarding attendance to the diabetes self-management education and training to an accredited program, and its impact, and it impacts insulin adherence in a positive way. And in general, those patients who are referred and can attend, and Cheryl talked about education for patients with diabetes, and of course we know the challenges and the cost of some of this education and how it's only covered in the primary care setting. We are fortunate here at our Baylor Community Care Clinic and diabetes program that we are now doing it free of cost to all patients. So, and we do see a relationship between those who attend all 4 classes, and they are 2-hour classes plus a follow-up with either the nurse, CDE, or the registered dietitian, have better outcomes. And that is one of our actually continuous quality improvement projects for the year, to have those percentages of patients that attend the classes and who improve their A1C.
And Cheryl, could you also just weigh in on the diabetes action plans and how effective they can be in helping to eliminate some of those barriers?
Well, I think what education and coming up with an action plan does is it gives that patient a shared ownership and a collaborative feel for being on board with how they're going to approach diabetes, so that, and also in education situations, rather than say, a one-on-one in a cold clinic exam room, they get to have those shared experiences. People speak up. Family members can come. They can chime in, and then they can also, everyone can just build accountability and rapport with each other to say, yeah, I'm feeling that same way too, and how did you come across fighting those feelings?
I think there's a role as well, for the diabetes self-management support groups as well that, many people offer after clients and patients have completed the certified diabetes education classes that, often, particularly in terms of when we look at people who don't have insurance coverage, or they may not have that option, but also being a part of a diabetes self-management support group, that also is very helpful in giving people the support they need for the lifestyle challenges that may also arise. So.
Right. And a big part of a truly, supporting and educating diabetes education program is showing that they have given that patient continuing resources, because where do you go from, the end of your 10 hours?
Right.
Yeah, and
exactly.
and how do you continue that support? How do you know when to speak up and say, hey, this is going on, or this has changed in my life, and how can you approach that? And that's why resources and support groups are so important.
Great. We're moving on to the next question. With the rising cost of insulin and cost being an access issue, are there any programs that any of the panelists can speak to which can assist patients with regards to the cost as a social determinant which impedes insulin adherence?
Right. This is Cheryl. I found the article, The Rising Cost of Insulin, that was found in several diabetes articles, very, very moving. When you think back from Frederick Banting, he sold the patent for $1 in 1921, and now, as this quotes in the article, insulin is like a $24 billion industry now, and the prices, the insulin, to me, this is my opinion, I think insulin is becoming big pharma, and they're looking for the big insulin trick that can do everything from, limiting hypo experiences to being longer and more sustaining as like an ultra long-acting insulin. So they're trying to get more and more fancy. Cost is a huge deal. However, you've got Eli Lilly. They're going to be partnering with blinkhealth.com to have a prescription discounted price plan. When you look at a lot of other companies, you've got the blinkhealth.com. Pfizer has RX Pathways. Then you have Sanofi has rxassist.org. So there's, aside from maybe a sliding scale or some kind of federally funded, hospital, like Grady, for example, has a Grady funding, formulary, that if patients have a prescription through the Grady pharmacy, they can get it through a Grady, if they're part of the Grady financial assistance program, they can get their prescriptions for a very low copay. But there are public assistance programs out there, and they generally start with the pharmacy that produces that product that the patient is prescribed.
Okay, wonderful. Outside of pharmacy claims data, are there any methods for tracking adherence?
I'll weigh in on that. I can. Yeah, as far as I know, according to the literature search that I've done, the only other way is through patient query, of actually asking the patients about the way they are complying with their medication. And this brings to light, an earlier discussion we had is about trust. You want to try to create the kind of relationship with your patients so that it is a partnership and they know that you are a partner with them in health. I was sharing that I had a recent encounter with a patient who I was doing a health fair and just reviewing her results. She'd recently been diagnosed with high cholesterol, was not taking her medication. She'd now been on a prescription about 6 months, maybe a little longer. She'd been picking up her medication every 3 months like clockwork, but was not taking a pill. And her physician was none the wiser. And so she was shrewd enough to know to get it on time, so at least if there was claims data, it looked for all intents and purposes that she was taking her medication when in fact she was not. And she was willing to share that information with me as a stranger, but probably just knowing that I really, I'm not going to say anything to her about it or whatever. And so I just can't stress enough, the need to have that kind of relationship with your patients so that they do feel comfortable. And I think Katia may have hit on a little bit ago, of not having a non-judgmental kind of atmosphere where your clients know that you want them to be empowered. And I often would say to my patients when I was in the clinic is that I really need this to work for you, because if it's not working for you, it's not going to work for you. And so I not only need the medication to be effective, I need this regimen, this whatever I'm giving you to work for your life, and you're the best person to let me know that.
I would like to add to that. A lot of electronic medical record programs have a way to be modified and tailored to what you're looking for. And I would encourage, if that is something that you want to track in a clinic, talk with your IT people. See if there's a way that you can put in a few questionnaire questions and pull that out, periodically for data tracking. And also, when other providers are looking at that chart, they will see those questions answered. There's tons of medication adherence, short bit questionnaires out there if you just do a Google search. And I think there's more room to incorporate them into electronic medical records and documenting.
Thank you very much. So our next question, and this will be our final question before we conclude. As the title indicates, this webinar was to discuss the health equity implications associated with medication adherence. So essentially, what are the drivers to achieving health equity in relationship to also achieving medication adherence?
Loaded question. Thanks, Sherilyn.
Yes.
Would anyone else want to weigh in before?
Well, I'll just say super fast that it's a complex situation that needs our best thinking hats, and it can be done and will be done because we are those champions.
Yeah, I love it. Yeah, I think, one of the things is that equity is achievable. We haven't yet, but we can. But we have to approach it from a systems level. And I know a lot of people don't like to entertain that conversation, but systems do what they're designed to do. And so part of the wonderful side of healthcare reform is getting at redesign of the systems. The way we've done medicine traditionally has not really worked to eradicate chronic illnesses and to manage people in the way they need to be managed. So with system redesign, it's possible. We just have to stay the course. It's hard. That I will agree to, but I do believe it's possible. So, and you can hear a violin playing behind me, I'm sure.
Yeah.
Sure. Would you want to add anything?
Yeah. No, I agree that it's a systems approach. It is a loaded question. Just equity and balance of health care across different populations, economic situations, belief systems, for different cultures. That's a tough one to handle, but I think as a practitioner, I like to say for trust, just be a team player, recognize the patient you're talking to and be reasonable for their expectations, be understanding to the best of your ability where that patient is coming from, and be sympathetic, and also just be thorough as to prioritizing, getting to the root of problems, and trying to see, I think as we see everybody as individual, then I think we'll break barriers in equity.
Thank you for very thorough answers to that very loaded question. And that brings us to the end of our time, and I thank each of you presenters for a very informative dialogue regarding the topic of drivers for insulin non-adherence in minority populations. And we thank each registrant and participant for attending today's webinar. Again, you can connect with us using Twitter via PriCareMatters and at our website www.primarycarematters.org. The webinar presentation has been emailed to you. However, the webinar presentation and the recording will be available on the Primary Care Matters site, and your post-evaluation will be following in order to receive CE credits and certificates of participation. And we thank you for attending today's webinar, and I hope you have a wonderful day.
Thank you.
Thank you all.
Thank you.